Welcome to this clinical skills lecture on assessing the apex beat. This tutorial discusses the ideal method for assessing the apex beat by covering the following topics. What is the apex beat? Patient setup and positioning, locating the apex beat, measuring the position of the apex beat, use of techniques to assist in finding the apex beat, assessing the character of the apex beat, and finally the interpretation of those results. The apex beat is normally produced by the left ventricular contraction and is the most lateral and inferior point of the chest where the cardiac impulse can be appreciated and is shown on this anatomical diagram here. As the apex beat can vary according to the position of the patient, this needs to be standardized. By convention, the patient should be sitting with their legs flat and the back at an angle of 45 degrees. In order to locate the most inferior and lateral impulse, it is important to start far enough around the patient not to miss this point. As can be seen by the video, the flat of the hand is used starting low and around the chest and brought back gradually to locate the impulse. Once they are located, the character needs to be assessed and the position pinpointed. To position the apex beat, it needs to be assessed vertically and laterally. The vertical assessment is made by counting down the rib spaces as shown. The apex beat is usually in the fifth intercostal space. The lateral assessment is made relative to the clavicle and is usually in line with the middle of the clavicle. Unfortunately, often the apex beat can be impalpable, as occurs in individuals with hyperexpanded chests. In this case, the patient can be rolled to the left side to bring the heart nearer to the chest wall and therefore make the beat palpable. If this is done, comments can only be made about the character of the beat. However, the location will now be inaccurate and should be treated with caution. Assessment of the character of the apex beat augments the information on the position. A dilated heart will move the apex beat, although not change its character. However, hypertrophy of the left ventricle will cause the beat to become more thrusting without any change in position. In mitral stenosis, if the first heart sound is very prominent, this can be felt as a tapping sensation at the apex. Therefore, when assessing the significance of the apex beat, consideration needs to be given to the causes of changes. Lateral and inferior displacement occur with volume overload, as can happen in either ventricular dysfunction or valvular incompetence. A thrusting apex beat occurs with hypertrophy caused by hypertension, aortic stenosis, or myopathy. Further impulses near to the apex beat need to also be appreciated, as these can occur in right ventricular hypertrophy or pulmonary disorders. I hope you enjoyed this tutorial and have learnt from it.